So good afternoon, good morning, good evening to all our guests from around the world. Welcome to the third in our series, Conversations in Virtual Care, brought to you by the Virtual Care SIG and in partnership with Apollo Hospitals Group. The recordings of the previous conversations are available on the IHF website if anyone's interested in listening back to those. So we're thrilled today to be joined by some wonderful panelists to discuss how we can build trust in virtual care. And this will be our final webinar before our face-to-face virtual care SIG workshop at the World Hospital Congress here in Geneva in November. And we really hope to see some of you there. So it is my pleasure today to introduce the chair of today's webinar and of our special interest group, Dr. Sai Praveen Harana from Apollo Hospitals. So, Dr. Sai, are you able to take the mic?
Hi, thank you, Lona. Not sure if my video is on and working.
Yes, perfect.
Great, thank you. Thank you all for joining in today. So as you know, the IHF has been spearheading some pretty cutting edge work, especially in the virtual care space for the last several years. And in the last editions of this particular conversations, we've had some very interesting discussions on a variety of topics which are relevant, including things like cross-border care, how to improve access. But this time we thought we should really focus on some of the areas which are not fully developed in many parts of the world, but are very mature in other parts. And this involves the regulatory aspects, the quality aspects. How do you make virtual care safe? What do you need to do to ensure that you actually are able to do things in a very regulated fashion so that the care is seamless between virtual and physical? So really invite all the attendees for joining in today. And we have an exceptional group of panelists today, and they will self-introduce themselves very briefly, but they span the breadth of the world. So they are from Israel, they're from India, as well as we do have people from other parts of the world, including the United Kingdom. So you have people representing very large health systems, as well as people with extreme amounts of experience in doing this in an implementation phase. And Ilona, of course, sits in Geneva and is supervising all of this around the world. And thank you again, Ilona, for doing this. So let's jump right in. We are, I think, going to have a shortage of time. So I'm going to be really quick. So Ilona, why don't you lead us to the next slide, and we can initiate the discussion pretty much very quickly. You want to put up the slide with our speakers and then the panelists, and we can kind of go from there. Perfect, great. So we have Dr. Barkai, who's from Sheba Hospital in Israel and Tel Aviv, and she has some extremely good experience, especially in a home setting of doing some very unique things. You'll hear about that. Rosina Hakim is with the NHS Confederation from the UK, and she will be talking about virtual care from the respect of virtual wards and has some very unique perspectives on the quality, safety, regulatory aspects of that. And Jay Ganesh is the executive director of AEHN, and he can talk more about what he does from that organization. But in his previous roles, he was instrumental in helping regulate a bunch of virtual care and a lot of, I would say, high quality, high risk delivery of care, especially in neurosurgery, as well as some other specialties. So let's jump right in. And I think what I'd like to do is actually begin by requesting Dr. Barkai to briefly tell us what's happening in Sheba, especially in terms of what she's doing, where she's extending care beyond the hospital walls, especially in a very unique setting.
Trying to unmute. Thank you. So thank you so much for having me here. Indeed, I'm Galia Barkai. I'm a pediatrician in training, and I've established just after COVID-19 Sheba Beyond, which is Sheba's virtual hospital, actually Israel's first virtual hospital. Sheba Medical Center is Israel's largest hospital. It has about 2,000 beds. And it's been on the Newsweek's list of 10 best hospitals in the world for the last couple of years. After the beginning of COVID, when we implemented telemedicine in our hospital, we have decided to take this one step forward and to establish a true hospital. So Sheba is a medical center with 4 hospitals. We've decided to establish Sheba's 5th hospital. It's not an innovation part of the hospital. It's a service delivery system that will develop new services with the intent to bring Sheba's care, tertiary hospital care to the patients in their home. So during these 4 or 5 years, we have developed several healthcare delivery systems and several programs in quite a lot of a variety of clinical fields: internal medicine, psychiatry, psychology, remote rehabilitation, cardiac rehabilitation, etc. And we have developed several systems to provide services at home, mostly by telemedicine, but some of our services are hybrid. We also have the role in Sheba to deploy telemedicine or hybrid services in each and one of the clinics, so to do a real transformation within the organization. And since we had the opportunity to establish services that are really first in their kind in Israel, sometimes in the world, we also help create the new regulation for these services. So at the moment, we have about 15 services and more than 115 clinics doing telemedicine in Sheba. We have more than 115,000 video visits per year in Sheba, which is approximately 12% of Sheba's outpatient services. And in each certain moment, we have between 500 and 600 patients in our programs, rehabilitation, home hospitalization, etc. Thank you.
Thank you so much, Tabarkai. That's very interesting. So I think one of the questions I would have is, how do you ensure that there is a, how are the credentialing of the staff done? So are they already Sheba staff, so it makes it easier? Or do you have to have a special protocol for the home area? How do you regulate that aspect of virtual care?
So regulation is one thing, credentialing is one other thing. So we usually will use or take Sheba specialists because we're known for our medical specialty. So usually we take our specialty for Sheba specialists. We sometimes hire people from outside, but then train them for the medical knowledge as Sheba. And then we train them both for home care and both for telemedicine. So in the beginning, before COVID-19 or at the beginning of COVID-19 pandemic, we created specific courses for people together with our medical simulation center. We had in Sheba a medical simulation center that also serves the Ministry of Health and other healthcare organizations. And we created a general telemedicine course in the beginning. But then, and so we went into some of the technical things, issues, but mostly we went into issues of how well should we perform communication between patient and clinician, and the special needs of controlling crews that are outside the hospital or in different areas, working in collaboration. So in the beginning, we had this training that was general, but then we understood we no longer needed that. And we tried to perform special training courses for special crews that work together for specific services. For example, for home hospitalization. So the certain aspects that are needed for home hospitalization. And then we decided each director of the group has to decide that the patients are well accredited to work with this. So this is how we train our personnel. Regarding credentialing, we don't have specific credentialing system that is national for it or organizational. We do it service by service.
Understood. Thank you so much. So I'm just going to invite now a little question for Jay. Jay, I know that you've been doing this for a bit. How is virtual care quality measured where you're kind of practiced the most? Now, I know you have an international role, but can you talk about what you did in India and what were the standards accreditation processes you used to ensure safe virtual care delivery? And can you comment briefly on your international role right now, and is there a difference between the two? I'm going to request you to keep the response a little brief because I know we'll be touching back on this again. So go ahead, Jay, please. Thank you.
Thank you, Dr. Sai. The first thing is like our concept of virtual care was like based on the need for extending the quality of health services that were provided completely free of charge by a public charitable trust in India. So the motive was predominantly that. And then so we went with the hospital information systems to look at from which states like we had the maximum demand, and then that's how the remote centers were put up. So the remote centers, by remote centers, I mean this is spoke sites. In the spoke sites, we did have the general physicians and then the allied health workers who were trained in the protocols, because ours was a specialty care, a tertiary care service. So that was like a post cardiac surgery follow-up or the post neurosurgery follow-up. So it had a certain protocol how to actually screen those patients. Otherwise, they would be traveling thousands of kilometers to the hospital. So there was this very specific protocol training given to the remote centers or the spoke sites, and then they were to actually do the screening and put the entire information back into the electronic medical record, and it was actually available to our specialist in the hub end or the specialist end. And then because they were already operated and then their previous records were already available in the hospital information systems, as well as the PACS, the imaging. So basically, what happens is after the post-surgery, they were screened, and then before they have the video consultation, their current information, whether it is labs or any other tests that are required, that information is also available in the electronic medical record. And then the previous history, including the surgery, what it was done and what was the status, is also available. And then during the video consultation, I would say that you have the complete information available. So that's how that we were able to ensure the quality, and then the staff were really trained so that like they don't miss out any cues that will otherwise can be picked up when they were in a physical visit. I hope that is a short answer, but if you have anything else, I'll be happy to share. Thank you.
We'll get back into these areas again in a bit. So that makes sense. And I think one of the questions that I was going to ask actually Dr. Hakim was about what the NHS does in its role in terms of the hybrid model. So I know that the NHS has a lot of virtual wards, but if you were to look at the national rules in terms of how virtual care is practiced, how do you extend that both from the outpatient virtual care and the virtual ward technically, which is an inpatient hospitalized patient? So Rosina, do you have any comments on how the NHS is doing that in terms of maintaining the quality and safety in both aspects?
Yes, sure. I hope you can hear me. Thank you very much for the invitation to this panel today. Yes, so for us in NHS, in terms of NHS England, virtual wards are very much a cornerstone of the NHS's current long-term strategy to modernise care and delivery and reduce very much the care from hospital admissions and moving patients from hospital care more into what we call the community, therefore trying to improve patient outcomes at a greater level. And virtual wards have been identified ever since the pandemic to help enable that hospital level care at home, but for remote monitoring using multidisciplinary teams and therefore using digital platforms. Of course, with any sort of digital intervention or care pathway, there are different levels of care that are delivered in terms of needs, in terms of step up or step down models, but the aim is for the quality to be just as good and robust as you would expect anywhere in the country. And some of the ways that is enabled is through making sure that there are clear, specific population health management data, so really understanding for systems and local NHS what it is that their local population needs. So currently for virtual wards, for example, there are some pathways that are mandatory, like frailty and heart disease. However, there will also be innovation in some NHS areas where perhaps children and young people have been identified as the area that would most benefit from coverage from a virtual ward. In terms of, I think your question was around thinking about what are the, how do you ensure that sort of governance and how do you ensure that standardization? I think there are definitely some challenges that there will be, especially if you're looking at addressing population level healthcare. We have challenges within the NHS in terms of level of demand, so ensuring we meet that demand by being as flexible as possible. So I think one of the beauties of virtual wards, but also hospital at homes, is being able to deliver that care at that patient's need. So whether that's offering a digital way of delivering care through that virtual ward, or perhaps they may not be suitable for that, and then bringing them into the hospital or community setting. And the mantra within that hospital at home is very much dependent on providing that choice. So identifying those patients and those people in the community that will not only benefit from virtual wards, but also essentially have that wraparound care around them, either through family, through social care initiatives. So ensuring that they are not just virtual wards alone, but what else can we make sure that we're delivering to ensure that continuous monitoring of outcome, safety, and improved patient experience. Another area, I suppose, where we want to ensure that there's that standardization and therefore that integration of virtual wards is making sure that virtual wards are aligning with predominantly primary care, community, and acute care pathway. So where is that intersection for the patient, but where is that intersection for that organisation as well? So that will be very much dependent not just on population health management, as I mentioned a few times, but also what are the strategic aims of that particular part of the NHS, what are the gains to be had from the NHS, and therefore what are the longer term impacts on the overall population of delivering that virtual ward experience.
Thank you, Razina. That's a very comprehensive answer. So I'm actually going to go back one step back before I go to the next theme. I have a feeling many folks don't know what a virtual ward is. Would you want to comment very quickly, or I could, on what I think a virtual ward is?
Yes, please go ahead, and then I can jump in because it might differ in the UK. Yeah.
So essentially, this might not be an issue for many places where there's no shortage of beds or you don't have any beds. Well, when you have patients waiting to get into a hospital, oftentimes the wait time itself can increase mortality and morbidity. And it's also that a lot of times hospitals are full and you just can't put a patient in for a while, and the patient stays in the emergency room for several days. So what they've realized now is that there is a possibility that many of these patients who need IV antibiotics, need an X-ray, need lab work, need a doctor and a nurse to see them, maybe need to do some physiotherapy, they don't need to be in the hospital. So they can actually be at home, and essentially you're converting the home into a bed of the hospital virtually. And you can provide services. You can have somebody come in and draw blood, somebody come in and check the blood pressure. So essentially you're converting a relatively safe environment for a patient who you don't think will deteriorate into a home-based care, which is already happening many places because they don't have a hospital. But in a UK, in a US, in a developed world setting, that is something that's useful. In an India setting, for example, at Apollo Hospitals, we do this in a way where we do early discharge for patients. We're able to discharge somebody who had a knee surgery, for example, early on. And some people don't want to be in a hospital. We can help take care of them at home. And this can advance to whatever level of complexity that you want. So that's what a virtual ward is. Thank you, Razina, for that nice overview. And thanks to the three of you for really covering this first theme of the topic, which was defining a little bit about what the quality and safety is. I know we went a little bit into clinical governance, but I'm going to very specifically ask about how does your organization manage clinical risk in remote consultation? Do you have like an incident reporting system, or how do you manage that, and how do you keep that tied up with the local regulations? So I'm going to ask Jay to very quickly comment on the telemedicine practice guidelines of India and how that kind of allowed people to do more in terms of the virtual care aspect.
Thank you, Sai. So the telemedicine practice guidelines came when the nation underwent the shutdowns. Like previously, it wasn't there. But in our case, it was like the clinical protocols, like what was actually followed in an outpatient department was exactly what we try to replicate in the remote centers. That was based on the templates. Like, for example, the data entry that happens into the electronic medical record itself is actually standardized. It's the same as it is used in the hospital. So there is like mandatory fields means it is mandatory. So the clinical documentation happens exactly the same way that it happens in a hospital. And then it is also checked by the consulting physician. And then, so that is one way of ensuring that. And then in terms of the standards, like since it is basically a web-based extension of the same EMR that is in the hospital, everything else is taken care. And then the rest actually is also like reporting. For example, like at the end of the day, we always look back, like somebody came with a particular issue, and then the person has gone back. Is there anything else that got added, or that problem got solved, or is there anyone who is actually coming for the virtual visits multiple times? We did have certain parameters by which we actually monitored. I would say that that's how we ensured things are actually taken care. And it was no different. Like our aim was whether it is virtual or it's in person at the hospital on site, it should not be any difference, because that's the way that because we ensure the quality or the safety, because it is only a virtual extension of the OPD.
Understood. So now that you know that he is, in terms of you're a new role, have you noticed any parallels or major differences in other countries? Is there something you want to comment on?
Thank you, Sai. So the telemedicine practice guidelines were during the time of 2020 onwards, like right, especially after March, like India released it on 25th March, I think, if I remember the day correct. But then there were many countries also in the region, they also came up with the practice guidelines. But if you look at the practice guidelines, I think it was at that point in time because of the social distancing, and then they don't want the hospitals to be overloaded. So it was in a way to encourage the home-based care, like rather than people coming around. So I think it was more of uptake. And then, so it was probably not very comprehensive, in my opinion. I think it certainly needs to be updated. It definitely needs to expand from what it was previously. I know of many countries introduced this, and then also some of the countries use that occasion to have a regulatory sandbox environment. In fact, to have the providers actually living up to the standards of care. So that was also done in some countries. So that I would say that the COVID was actually a trigger for such practice guidelines, and then also standardization. But then, like, I think it doesn't need to, because now probably like people are didn't kind of get beyond that. Probably there is a need for harmonization of those kind of standards as well as a regulatory environment, because I think that probably that part is currently missing in most of the countries. What was begun was probably did not get extended or updated beyond emergency situation is my quick response. Thank you.
Yeah, I think you're right about that. In many ways, they've kind of gone back to the pre-COVID era and all the rules and regulations, and haven't, I think, used that opportunity. Believe it or not, we're 25 minutes into this webinar. Time runs fast. So Dr. Barkay, up to you now to share with us, how do you deal with workforce competence and training for safe virtual care in Israel? Are there competencies you measure as new roles evolve? I know you mentioned a little bit about the home-based thing, but in general, are there standards that are changing? Like, do you think there are any formal ways of integrating virtual care training into medical education, for example?
So before I answer your question, I want to agree with Jay. I think that the standards are not very different from virtual care and regular care. So we have to stand for the same standards. In Israel as well, we have national guidelines and organizational guidelines for telemedicine and for home hospitalization, which are different. And the main thing is to know how to choose your patients, know how to choose the right use cases and the right patients for this. And once you manage to do that, you need less regulation on how you do it, and the standards should be like the regular ones. Of course, you have data security and all these things, but it should be easier. So we still don't have, regarding your question about training and competencies, we don't have in our medical schools yet specific training for people performing hospital at home or telemedicine. We have in some of the universities special courses for telemedicine, special courses for hospital at home. I'm trying to integrate this into our medical school in Tel Aviv. So hopefully maybe next year we'll have that. But definitely the new clinicians will need to know how to perform both care at home, hospital at home, how to take care of a patient outside of the hospital area. This is one thing, and also how to use technology wisely and safely, and it will be part of the work. And we're talking now about telemedicine, but when AI comes in, and this is now, it's not like in a few years, they will have much more things, and then training should include that, all medical schools. We will have new roles. We're seeing them in Sheba Beyond already that are more moderators, people that manage teams that are distant and are in the homes and in the hospital and doing different things. So we'll have more moderating teams and other teams as well. We have developed in Sheba Beyond a technical support center and a training center for our technologies, or for our clinicians, and even for our patients. They can call our call center and have technical assistance, technological assistance. So we'll have these as well as new roles that deal with that. We have a whole group of tech people that help us integrate new technologies within our systems of the hospital. So every time we integrate a new technology, we have a cloud committee, we have many work to do integrating them into our EMR and our systems. So these are roles that we'll have to develop as well.
So what you've told me really is you need a technical support as well as the clinical piece, as well as essentially coordinators to make sure things run well. So just like any program. That's great. Thank you. So, we've talked about examples of virtual care in England, as well in the UK, as well as in Israel and India. We've talked about the workforce competence and training requirements. We've also talked about the clinical governance, the regulations out there, and all in the last 30 minutes we've kind of done a very high-speed round of all of this. Now, one question to Rosina would be, in the NHS, how do you handle this piece, especially what Israel's doing in terms of the competence and the care coordination? Are there specialized courses that people are doing for the virtual wards? How do you ensure that a virtual ward in one location is similar to another one? Are there any kinds of similarity in these?
Yes, I think with virtual wards, and colleagues on the call have already mentioned this, and I would like to also reiterate that virtual wards, the aim of virtual wards is not differ at all in terms of governance, oversight, or clinical efficacy to that of physical care. The difference should be very much around meeting the patient in their home and making that far more accessible. So with that in mind, it's really making sure that the quality of the care is very similar. So there are a lot of similarities in what a model should look like. So for example, there should be effective governance, and every single virtual ward is clinically led. So you will have a consultant physician, a general practitioner or advanced practitioner who is effectively leading and is in charge of that specific virtual ward. We also have very stringent guidelines and frameworks where each provider of virtual wards must be registered with our Care Quality Commission, which is our regulatory body in the UK, which oversees all levels of care, whether in hospital or at home. We also have various levels of legal and procurement frameworks that are underpinned by legislation or under a specific sort of provider selection regime. So ensuring there's that standardization around the overall framework of a virtual ward is essential. However, there should also be flexibility in how you deliver that virtual ward to ensure you're meeting your patient where you wish to. So as I mentioned earlier, there are standard pathways. So there's a respiratory, there's frailty, there's COPD care pathways for virtual wards, and how patients are chosen is very carefully chosen depending on their level of risk, their level of need, and also how available staff is within that area. However, where the changes will be around whether the different types of technology that is used. Do you do remote monitoring in between? Is there wearable tech available for that virtual ward? Is there a way of ensuring that you have a bigger multidisciplinary team who are at your that you're available to message, to have access to via text message, for example? Not all virtual ward systems will have that more deeper understanding of digital or technology enabled. However, the overall principle and framework of what a virtual ward should achieve should be standardized across all of the UK.
Great, thank you. Now, there's a few questions coming in the chat. We'll hopefully get to them relatively shortly. By the way, Ilona, I know Jay's been putting a bunch of interesting links. Are they going to all the attendees? If not, can you transcribe them into the all attendee chat? If not, we can do it later. So I was going to ask this question to Dr. Barkai again. Now, in the Israeli model of care, so do you have a situation where you actually do virtual care, but only deal with information, meaning you're not seeing a patient, but you're actually only looking at, say, data? The reason I ask is I work with certain health systems within the US from India, and in that setting, we are doing fall detection where I can't see the patient. I'm only looking at information about where the patient's located in a room. I'm also looking at a situation where I'm only looking at vital signs data from my patients in India, where people are not in the ICU, but all of that data comes into my command center. I'm looking at their vital signs to kind of triage them as to sick, not sick, and pretty good outcomes evaluating those patients across India, quite a large number, and we've talked about this in previous webinars. So in that kind of a setting, do you have any insights, Dr. Barkai? If you're just getting signals in, but not seeing a patient, should rules be different? Do you do something of that sort? And Jay, you can comment on this too right after Dr. Barkai.
So specifically in my organizations, we usually give care to persons that we connect with, we communicate with, and we give care. And many times we use data that arrive from the patient as well, but we also connect with them. For example, we have a program of remote cardiac rehabilitation. So the patient has a smartwatch and an application, and we can, and the whole staff and the patient himself can see the activity he's been doing, his pulse, his steps, and he can answer questionnaires, et cetera, et cetera. And so we both communicate and both receive data. And I think the data is very important because for the first time we have ongoing data. So these are not patients to which we have to respond, in urgency. So it's a remote rehabilitation system. We can count on data from a smartwatch because it's not sick patients at home. It's a rehabilitation program. So we specifically don't have these programs. We have other programs of type 1 diabetes patients at home. Also, diabetes is very much a disease of data. Yeah, you have to gather a lot of data regarding glucose, your insulin, what you ate, your activity, etc., etc. So we have a lot of information and data coming in, but we also communicate with our patients. Moreover, in Israel, as opposed to the United States, we don't have codes, reimbursement codes for remote patient monitoring. So we don't have programs in which we just monitor patients remotely. But I believe, and we're trying to work on this now, that when we use more AI tools, we can do many of the other things that usually are needed when we connect with the patients on the same time. So we can do the triage, we can communicate through the AI tool, the chatbot, etc. But I think that will happen more in the future when we use more AI. We won't have to communicate as much with the patient. We're doing research now on, for example, ICBT treatment. So it's instead of meeting the psychologist, the therapist, the patients will have an application, and we're trying to see if it's the same and the outcomes are the same. And we have good preliminary results, but it's still part of our research that we're doing in our psychology clinic. But it should be that way in the future more.
Great. I mean, that's super interesting. Thank you for sharing about that. And Jay, do you have any insights? You look at the global perspective. Do you think signals-based telemedicine should be any different than direct telemedicine? Do the regulations need to be any different?
I think it probably needs to. It depends also, like, because most of the practice guidelines usually say at least there should be a first contact in some cases. So unless otherwise, like we are kind of a routine monitoring of health or probably wellness, I think most of the clinical cases actually insist that there needs to be a first contact. And then, like, for example, even in India, like the telemedicine practice guidelines clearly mentioned in specific cases where there needs to be a contact, and then also probably the duration, like how earlier that they had this first contact, and then of course the rest of the things happen virtually. Even in our case, like that we had multiple cases, like because of the tertiary care nature of this, like we always made sure that we had the complete data of the patient collected at the remote end, and then had this video consultation with high quality video. But then we also had an occasion where we actually need to reach out to cases which probably did not need it. Like, sometimes the routine cases also reach out, but so we had a way of triaging them. So it was done on a more case to case basis. But to answer your question, Dr. Sai, like I think most of the telemedicine practice guidelines do say that do's and don'ts, and then also give certain scenarios. Most of them insist to have a kind of a rapport or a prior contact with the physician. That's how it happened. But of course, there are occasions when people are actually sent back to be monitored on an RPM. I think that means that the case is actually well known, but certain things needs to be monitored on a more regular basis. That is done remotely. That's how I would put it.
Perfect. So I don't want to complicate our lives, but with I'm sure all of you fly a lot, and you've had medical emergencies on board flights. Now, when a baby is born on a flight, I understand that they belong to the country of the airline sometimes, or there's different rules on which country that baby belongs to. But in terms of virtual care, you can do virtual care from airplanes now. And now with Starlink and high-speed internet, your internet bandwidth is going to be better than what we're doing today. And I've seen that. I've had Teams meetings where I'm the only one on video on a flight. But what do you think? This is a hypothetical question, but should the rules change for aviation-based telemedicine, for marine-based telemedicine, or you're doing telemedicine from a non-traditional site? What do you think are the safety things you have to think about? So I'm going to ask Rosina, just based on, it's a hypothetical question, but if you were to involve yourself in this protocol to make it safe, what would you think you should do? And I'll run through with Dr. Barkay and then Jay to answer this question for me.
Thank you. That's a real hypothetical scenario, but in terms of what I think should be safety and non-negotiable are thinking about the core capabilities of any service, regardless of where it is that you're delivering it. So you mentioned there in terms of the type of digital or how great, the broadband or the service may be. Yes, that is one area, but it's really essential to make sure that that clinical decision making in whatever setting you are in is as robust and as safe and as governed as much as possible, no matter where it is that you're delivering that care. Similarly, if you are going to be using a level of virtual or telehealth care, or in terms of any remote monitoring, that digital literacy, both for the staff and most importantly for the patient, is that tool, the monitoring capability and ability to share that information is essential. Otherwise, that's where a lot of the gaps and a lot of the risk can really be felt. And then the other area I think would be really important, again, no matter where it is that you're delivering that care, is really ensuring that risk assessment and escalation protocols are in place, so you have a wider team around you. If you need to escalate or if you need to step up care, where do you then go for that support? How do you ensure that risk governance is surrounding that situation? And I think in your hypothetical situation, I think that makes it even more of a challenge. So how do we ensure that? And we can only ensure that by making sure that we have the right staff in place, but also they have the right core capabilities and the tools available to them to have that really good wraparound care.
Perfect. You did perfect. 10 on 10, Rosina. But let's see what Dr. Barkay and Jay want to say about this.
I have to say that, first of all, when you're in the air or in the middle of the sea, many times, this is the only thing you may have is someone help you from abroad. So this is the best you can do. So you may as well take it. But I think that the basic thing of this is to create from the beginning, when you create a service like this, to create the right protocols and define the escalation protocols and where you go to, and make sure that they have remote monitoring systems that are easy enough, that the staffs are trained and they know how to communicate. So you have to, you can make this work if you make the good protocols and the right training programs and you use the right technology. What we sometimes have to deal with, because we do cross-border telemedicine, we sometimes consult Israelis or non-Israelis across borders, and sometimes even we have Israelis staff that work from abroad because they move abroad and they continue to work with us. So of course it's the insurance thing, because regulation is very different from different countries, and the insurance sometimes in the United States, in different states, they have different regulations regarding who can give you care, who you can give care to. So we try to extend these regulations and say, if it's our patient, even if maybe he's out of the country, but he's insured by an Israeli system, and we're Israeli physicians, we can extend our hand, lend our hand, and continue to take care of it. But these are issues that you have to deal with when you do cross-country telemedicine. Sometimes it costs a lot of money for us to insure our staff, because we of course are accountable for our staff, and we make sure they're licensed to provide the care, and they're insured to provide their care. So this is something that sometimes is costly, but you have to deal with it. You have no choice.
Perfect, thank you. And Jay, very briefly, your thoughts?
Yeah, thank you. I agree with what Dr. Bakai said, especially I think on the protocols, because not every time the crew is the crew is not necessarily doctors or healthcare staff, but they need to know the protocols to handle. But I think with experience, like most of them would have gone through such training. But to have such equipment also, like for example, vital signs monitor on board, and then being able to transmit that, and then to have somebody, wherever they are flying, but as part of the airline, if they have a set care provider who is already in contract with them to actually continuously monitor in such cases of emergency, and being able to actually guide the crew. Because usually what happens in the airline, like you are aware, that most of the times they actually ask for if there any onboard physician available, and then they are actually asked to come. So in case if even that does not happen, then like what happens is it's left to the crew to deal with them. And then also they actually consider, depending on the kind of emergency, whether to actually land in the nearest possible airport.
Absolutely. Yeah. I'm sure physicians on the call and Dr. Barsam have faced this before. I have faced it, where there was a situation where we were over the Arabian Sea, and luckily we had Wi-Fi on the flight, and I actually connected to the cardiologist in my hospital and did a virtual consult with the patient with chest pain, and we didn't have to divert, which is good because I kind of want to get to my meetings.
I just wanted to add one more.
Yeah.
It is interesting that you are asking this question. I remember 20 years back when I was actually getting started with telemedicine, and there were designs on board on both Airbus as well as Boeing. There were designs, they were talking about having a medical station on board, and exactly to do this. Thank you.
Interesting. Very interesting. This can go on, but we're already at 44 minutes into our meeting. I'm going to very quickly open up to 2 to 3 chat questions. If there are any, Ilona, I'll let you look and let me know if there's any questions going on. But while that's happening, so we have so far talked about serious examples of where this is actually happening, the virtual wards, the Israeli example of home-based care, as well as Jay's examples of global, especially India-based telemedicine. In addition to that, we have gone over what defines quality, what defines safety, what the regulatory differences, as well as a little bit about the governance and risk management in these settings to ensure that everybody has the right training, as well as how to manage the new roles and the role for coordinators, as well as looking at what is required to enhance the training, especially in medical education, both for doctors and nurses. We also talked about some global benchmarking. We spoke about what the outcomes we need. And there is one question from an attendee asking about, is it possible to set a worldwide platform for virtual care, which is home-based? would you recommend it? So very briefly, can the attendees run through the panelists? Kindly just offer your comments on those, please.
I'm happy.
Yeah, go ahead, please. Rosina, go ahead.
Really.
Sorry, I suppose for me it would be, what is the purpose of thinking about designing why would we want that? What would be the need and for whom? So if it's for joining up care, if it's to enable travel, if it's about risk stratification, is it about prevention? So really understanding what that purpose is, because very often our experiences with virtual wards or anything that is a digital care pathway, that the idea of having that pathway seems more lucrative and valuable than the reason for why it was developed in the first place. So really understanding that methodology on what is the impact that you're trying to achieve is probably what will drive that ability to have an integrated worldwide pathway. And the other thing I would probably say, as maybe controversial, is the funding for that, where and how and where would the governance, where would the scrutiny and where would the cost sit? And I think those will be huge barriers as to probably why we don't have that joined up care currently.
Great. And Dr. Barkay, do you foresee a single platform?
Yeah, so we can do a worldwide platform. I don't think that it's applicable for home hospitalization. It may be applicable for consultations, for I don't know, rehabilitation programs maybe. If you go through the insurance things and the protocols and the language burdens and all these burdens, it can be possible, especially if it's something for simple consultations at Q&A or for I don't know, problems like that. For us as a tertiary hospitals, many of the time the programs that we develop are for high acuity patients, like in your virtual wards, like in other. We also have a home hospitalization program for pregnant women with high risk pregnancy, for example, which is quite innovative. For this, you have to have a connection to the brick and mortar hospital. When the patients are deteriorating, they have to get very quickly to the hospital. You have to know who to talk to and make sure that they're well being taken care of. So for the higher acuity patients, even if you go through all the other burdens we talked about, I don't think it's possible. You should better be close to a brick and mortar hospital and have very good collaboration with. So
I think that's perfect. I'll just give a quick example, Jay, before you jump in. So I had a patient once who was really short of breath, and the son was with the patient, and the father, they were doing a virtual consult. One look, and I knew that this is not suitable for virtual care. And what happens is that sometimes people get, they get used to their illness, and they don't realize how sick they are, or they don't have the devices could be malfunctioning. So I think it's very important as providers of telehealth and virtual care, you know when not to use it. You need to make sure that you don't do it in an unsafe setting. And I actually had to call an ambulance with a patient to the nearest hospital. It was a different city, but I knew the doc in the town, so I actually called and got an ambulance to the house. So I think it's important to recognize when not to do it. And I'm going to quickly ask Jay. So Jay, is there a return on investment perspective to this whole aspect of virtual care? Like if you were to maintain quality, ensure safety, and if you were to think of that as your ROI in virtual care, forget the financial part of it. What do you think would be the top 1 or 2 things you should think about if you want to ensure that your ROI is truly quality and safety?
I think, as you said, ROI depends on who is actually providing and what is the motive. I think for most of the physicians, I think being able to actually provide the care to the patients by itself, that satisfaction itself is part of the, I would say, return on investment. And then also professional satisfaction. I've seen occasions, for example, where this has actually led to professional development also. So that is also, I would consider a return on investment. And then, I would say that not, as you said, exactly, it need not necessarily be monetary, but of course, we have to make sure that the program actually continues in terms of sustenance. So that's how I would look at the ROI, how we could actually optimize the services in such a way that this exists beyond any external support or grant, because sometimes the telemedicine programs actually flourish when there is an initial grant, but after that, like it just dies. So how we can sustain it? But I think that depends when there is a local support. I remember one of the countries that I was involved in advising on the telehealth strategy, that whole lot of equipment that had come as part of the donor support was actually from abroad, and there was no one in the country actually trained how to operate or how to actually maintain such equipment. Very expensive, very good equipment, but then in the local ecosystem, there was no one to fix even a power adapter. Then I found by traveling to those sites, there were about 14 sites in the country. They call it remote telemedicine centers. And those issues were not with actually the equipment, it was just with the power adapter, which wouldn't cost probably maybe $5 or less. But then the whole equipment was not working because there was no one in the country to support. So I think thinking in terms of the local ecosystem, how to support and sustain such services, I would say that it's also part of the ROI, needs to be planned.
That's perfect. So, I mean, I remember, the battle was lost for want of a little screw on the wheel, right? So that's the example I remember. But I think, what the other thought that came to me was ROI may perhaps mean return on inspiration. I mean, you're really looking at these model projects and trying to get inspired and build something else. And I know you've seen many of those in India and other countries. So I think that's a good segue into our last segment. Ilona, any other questions in the chat? Do attendees have other questions? I know there are quite a few people still logged in.
Thanks, Dr. Sai. Yeah, we have a question from Isabel in the US, just stating there are big differences in income, and the disparity means there are groups of people that may not have access to a smartphone or reliable Wi-Fi, and how can we counteract these challenges?
Oh, that's an excellent question. I'll take a quick stab at an overview on that. I think this is a critical piece, not just for the US, but there's a big rural-urban divide. There's a north-south divide. There's an access divide based on, electricity access, for example. And we did discuss these on one of our previous webinars, and, we can highlight those when you Google search this webinar series. We touched on those. But let me ask Dr. Barzai and Dr. Hakim, how do you handle that in the NHS and Israel in terms of the equity of access to virtual care, not just from a Wi-Fi or a smartphone, but in general, being able to provide it? You have only about 30 seconds each. Please answer that.
So I will say that in Israel, you have Wi-Fi almost everywhere, and almost everyone has a cellular phone, even in the poorest places. But you can also do telemedicine by using regular phone. So you can do very simple things with cheap technology, and some of the things don't require more. I know in some of the country, they're talking about putting kiosks in rural areas and deploying like kiosks, made possible by community workers and stuff like this. I still haven't seen these models succeed, I have to say. So it's a real problem. You have to think about it when you develop a new service or new kinds of service to take care of remotely, because you always want to increase equity in care and deliver care everywhere. That's what we say. But you fear you can find yourself, if you choose very expensive technologies, if you don't have regulation, you don't have reimbursement models that work for it, you can find yourself by giving services to just the rich ones, the closest ones, and not the ones that need it the most and are in rural areas and dispersed. This is something that you have to take care in your national level, I think.
Sure. And Dr. Rosina, what do you think?
Yes, I think that's a really, really important question. And these issues around using virtual wards or virtual care have huge risks around widening health inequalities, especially for vulnerable populations, not just from lower socioeconomic backgrounds, but those who are homeless, for example, or have multiple health conditions. And this is something that the NHS is hugely challenged with and acutely aware of. So despite efforts towards digital inclusion, many patients still do face barriers due to poor broadband access, data costs for video consultations being quite high, and then of course lack of devices or digital literacy. Even if, you know, as we know nowadays, everybody has access to a smartphone. Yes, they may do, but it does not always mean they have that digital literacy, or English may not be their first language. So there are various barriers. And the one way that the NHS has tried to overcome this, again, depends on the population and how the funding is distributed. But some virtual wards, for example, will lend out and support through iPads by paying for data costs on mobile phones. And then, of course, as I mentioned right at the start, the essential component of any virtual ward is providing a virtual ward alongside physical healthcare. So the purpose of virtual care is not just to provide virtual care alone, but to provide it as an alternative and a complementary means to support productivity and that pressure on demand. So the idea is that you will always get demand from patients wanting to go into a physical building, as well as those who would like to use their phones or digital devices.
Great, thank you. We're almost time, but I'm going to quickly ask, well, I'm calling it a quick fire round, but we've kind of touched on a lot of these themes. But if you really look at virtual care, we talked about regulations, we talked about the priorities that we need in terms of making sure it works well, the technical aspects, the competence of the providers who are doing this. What would you think is the biggest challenge in ensuring quality and safety in virtual care? Very briefly, Jay.
I think it depends on the clinical documentation. If it is not usually captured at the point of care and somebody does it and it is not verified, that is a risk. So I would put that. And then also like interoperability, because often the registration, data collection happens at multiple points, but then if it is not available for any extended care, it is also a risk.
Perfect. So documentation, interoperability, which is probably the same for even regular care, not just virtual care, but I think it's critical that we look at that. Dr. Barkay.
So I think the greatest challenge is the adaptive change we have to undergo, mostly as clinicians. I think for the patients, it's easier. They would rather be at home. They would take telemedicine. I think especially us physicians are the most conservative persons. And what I find in trying to integrate wide scale telemedicine adoption in Sheba and in Israel is the personnel, the medical personnel that really need to undergo, and you have to understand it, a great change in the way they're providing care. It's very different than what we've learned. So absolutely. I think it's a major issue we go through.
Good point. And Rosina.
Thank you. I think sort of for a very successful virtual ward, it's really important to co-design from the start of the process of implementing and looking at what your methodology is. Why is it that you need a virtual ward as opposed to something else? How are you going to co-design it with your patients, and how do you co-design that with your workforce, especially those who are leading that from a senior level, so for a senior clinician buy-in, and making sure you have that long-term consultant and long-term investment in their success of that virtual ward.
Perfect. So I think what I'm hearing really from all of you is that it's a team effort, and to me, team stands for together everyone achieves miracles. And in virtual care, you can actually do quite a bit. There are situations I have personally been involved in where just because it was a virtual appointment, they were able to save fossil fuel, they were able to save money, they were able to not travel unnecessarily and actually make a difference in the outcome. At the same time, we do know that there is a big requirement for ensuring safety, ensuring quality, and making sure the regulations catch up, honestly. So that, I think, is where the next phase of this is going to be. So Ilona, thank you so much for coordinating this wonderful webinar and identifying our speakers, and great, really nice discussion by our teams from Dr. Barkay, Hakeem, and Jay. Excellent overview of 4 or 5 geographies. And Ilona, when is our next session? Is it going to be in Geneva? You want to talk very briefly about folks who can make it to Geneva?
Thank you, Dr. Say. Yep, the next virtual SIG meeting is going to be face-to-face workshop at the World Hospital Congress here in Geneva in November. The details and the link are in the chat, so it would be great to see many of you there. And otherwise, we look forward to a new conversation in virtual care, January 2026, after the face-to-face event in Congress. So thank you so much to our panelists and to Dr. Sai. Wonderful to have you chairing, as always. Thank you for your leadership on this, and have a great afternoon, evening, everybody. Thank you so much.
Great.